بسم الله الرحمن الرحيم. النهارده واحدة من الكلينيكال راوندز اللي في الكلينيكال اوفثالمولوجي related to the external appearance. أنا دكتور مجدي موسى، أستاذ طب وجراحة العيون ورئيس القسم طب وجراحة العيون في كلية طب طنطا. هتكلم على how to examine the patient and the external appearance signs اللي احنا بنشوفها. البلان اوف كوندكشن ان احنا نعمل شورت انترودكشن 5 minutes ايه هو الاكسترنال appearance واكسبلانيشن اوف ذا بيزك برنسبل بنستخدم ايه، وحاطين بعض الفيديوهات الديمونستريشن وعاملين تايم فور براكتس ان انت تراجع وتشوف الداتا اللي انت استفدت منها ايه. الاكسترنال appearance examination, our objective is to identify the components of external appearance examination with steps of measuring the amount of direction of protrusion of the eye or what we call proptosis, and detect التروبيا اللي هي السكوينت او deviation of the eye using Hirschberg test و measuring these tropias in degrees or diopters by very simple method. خلينا نشوف ايه اللي هنشوفه في الاكسترنال appearance. What are we going to see in external appearance? When we look at the patient, we have to inspect the face in diffuse light and always compare both eyes. We have to compare both eyes, any asymmetry between both eyes, and the relation of the eye to the surrounding structure, to the bone, to the nose, to the cheek, and direction of both eyes. Are they parallel or not? This means they are deviated or not, and inspection of the surrounding structure which might affect the eye, like the eyebrow, the lids, the lacrimal gland, lacrimal cyst, and inspection of the eye itself for any abnormal coloration. And we have to expect at the end, to examine at the end what we call the red reflex. What is the red reflex? It's the reflex of the light reflected from the pupil, and this will be explained thoroughly. Let's go to the inspection by naked eye and using a torch of light. What are we going to look for? The most common presentations we are looking for is wrinkling of the forehead. لما الجبين بيتقطب أو تلاقي تعريجة في الفورهيد. Dropping of the upper eyelid. We call dropping because in the external appearance we should not use medical terms because sometimes it change. Like ptosis, it's called dropping of the upper lid, or the lid is retracted more than normal, pulled up. Third thing, abnormal head posture. If the patient is having the normal head posture, or it has a tilt or turning the face into one or another side. Then we look at the globe. Is it in normal position? Is it protruded? Is it retracted? Is it small? Is it larger than normal? And then we look at the ocular deviation. Then we look at the periorbital masses, tumors, ulcer on the skin surrounding the eye. And then we look at the eye if there's any discharge coming from it, or we look at the color of the eye. We all know that the sclera is white, so there's no coloration. If there is any red color, like on the sclera or on the cornea, we will explain that. Let's go through the journey of external appearance. First thing, as we said, a wrinkling of the forehead. Look at this. There is wrinkling of the forehead. This means that this patient is wrinkling the forehead because he's using the frontalis, and it happens in cases of severe bilateral ptosis where the patient is trying to use the frontalis to elevate the upper eyelid to be able to see better. And this is a very good diagnostic sign of bilateral severe ptosis. Then inspecting both eyes, looking at both eyes. What is the normal position of the upper eyelid to know if the upper eyelid is dropped or not? Is it dropping of the upper eyelid, which we call ptosis? If there is difference between both eyes. So what is the normal position of the upper eyelid? The upper eyelid is normally covering the upper 1/6 of the corneal diameter. Normally the corneal diameter is from 11 to 12 millimeters, so covering the upper 1/6, it's 2 millimeter covering of the cornea. So it means if it covers less than 2 millimeter, or at least we see the sclera, it is retraction of the upper eyelid. If it covers more than 2 millimeter, it is dropping of the upper eyelid, and the illustration on the left side showing that 2 millimeter is actually the upper eyelid covering part of the cornea. And the other diameters are the palpebral fissure and the distance between the lower lid and the upper lid, and lower lid and the crease of the upper eyelid. And here's example. Dropping of the upper eyelid. It could be unilateral, like this patient. She has dropping of the left upper eyelid, and it is mild. Now we can see how the upper eyelid can be severely dropped and covering most of the cornea, more than 6 millimeter, and this is a severe. It could be also bilateral, and it could be moderate like this. So it could be unilateral, could be bilateral. It degrees from mild, moderate to severe depending on how many millimeters it covers. Then it comes the lid retraction, which is the opposite of dropping the upper eyelid. In this case, we have left normal upper eyelid, which is covering about 2 millimeters of the cornea, but on the right eye, we can see that the upper eyelid is not covering the cornea at all. Even the sclera can be seen, which we call it lid retraction. Lid retraction could be bilateral, and it gives sometimes like a staring look. When you are staring, it looks like a staring look, but this is normally the patient is not staring, and this is lid retraction in both eyes, and we can see there is a mild difference. Right eye, we can see that the lid is almost at the limbus where the cornea ends, and in the left eye we can see the limbus and part of the sclera. So it has also degrees of lid retraction. Looking at the eye while opening or looking at the eye while it's closed. So look at this patient, the right eye is closed, the left eye is closed, but there is part of the sclera and the cornea is seen, and we call this lagophthalmos, which incomplete closure of the eye during closing the eye, and this means that we have defect in the muscles closing the eye, and we can see this in the seventh nerve palsy when the patient try to close his eyes and go to sleep, part of the eye is exposed, and this is very important to detect this patient. Or sometimes he's closing the eye completely, but still the eye is covered. Why? Because there's defect in the lid, congenital coloboma. Part of the lid is missing, so we have to notice this patient, and even only inspection can give you the diagnosis. Then we can have a look on the patient head. He is facing you, so he has to be a straight head. Any abnormal or compensatory head position, like head tilt, like face turn, like chin elevation, like chin depression, has meaning. Head tilt means that one of the obliques is paralytic, especially the superior oblique, because it has separate innervation. Face turn, horizontal recti palsy. Chin elevation, superior rectus palsy, and chin depression, inferior rectus palsy. And we will have some examples like this patient. It has abnormal head posture. The chin is rolled up, and it can be seen in superior rectus palsy because the patient is pushing the chin up to make the eyes go down, so it has a better field of view. Abnormal head posture. Look at this patient. The patient on the left side, a male patient, is tilting his head to the left. And this happened to the left, means left shoulder. We are related this to the shoulder. So this is compensatory head tilt to the left shoulder. It happens in cases of right superior oblique palsy. When he has superior oblique palsy, he tilts the head, so both eyes will be parallel. If you tilt the head to the right side, you will see the tropia, hypertropia, you can see it clearly. On the left side, this is a compensatory head position to the right, which means to the right shoulder, and it happens in left superior oblique palsy to compensate for diplopia. The patient will see things double if he keeps the head straight. And the most important thing is to detect children with this. Sometimes these children, they adapt this position because they don't know how to complain, how they can see double, they don't speak. So most of the time when you face a child, look at the child with a head tilt with his mother or his father or his accompanied person, and this head tilt sometimes is interfered by many doctors, like neurosurgery. They make like a spasm of the neck muscles. They do surgery for that. It is not the cause there. The cause is in the superior oblique. They have congenital superior oblique palsy, and we can see he's tilting to the left side. So he had the right superior oblique palsy, and he's adapting this position to compensate for the diplopia, and he can see only single vision by doing this head tilt. So it's very important. By inspection, you can detect that, and it's easily to detect it in these children. The globe, looking at the globe, is it in normal position or it's protruded outside, which we call proptosis? Exophthalmos is another medical term, so we use proptosis, which means protrusion of the globe itself, and it could be proptosis, it could be inophthalmos, retraction of the globe, and it could be atrophic globe, and for certain it will be inophthalmic. The picture on the left side, it's called unilateral proptosis. We can see how the left eye is protruded. The picture on the right eye had a bilateral proptosis, which can be clearly seen. And it happens in severe exophthalmos, in thyrotoxicosis. This is happens in thyrotoxicosis. And we can see also other signs like puffy lids, like lid retraction. These are all manifestations of thyrotoxic goiter. Proptosis has to be seen in direction and amount of proptosis. Look at the direction for the boy on the right side. It's down direction, so we have to expect that the mass is pushing the globe anteriorly and down, so we have to look at the superior part of the orbit or the roof of the orbit where the tumor mass can come from there. Axial proptosis means there is no sometimes mass. It could be because of the thyrotoxicosis, but again, axial proptosis means that something is pushing the eye from behind, and we all know that in thyrotoxicosis it happens because of the orbital fat is pretty edematous and it's pushing the globe anteriorly, and this is axial proptosis on the right side. How can we define the degree and the amount? We have to measure this by ruler, putting the ruler at the angle of the eye at the orbital margin, the bony orbital margin, and measuring the amount of proptosis from the lateral point of view, as we can see by the ruler up there. Or we have something called exophthalmometer, which can exactly measure how many millimeter protrusion in millimeters in both eyes and the difference between both eyes. But this is a way to measure that, but this is not by inspection, this is by machine. Again, inspection by naked eye, we can see the difference between both eyes. On the left side, this is a male patient, and we look at the left eye, we can see ptosis, but this is not actually ptosis, this is a pseudotosis, because the eyelid is dropped down because the globe behind, the globe inside is small or atrophic, so there is no support for the eyelid, so that's why we call pseudotosis, and this is an enophthalmos complicated by or seen as a pseudotosis. On the left side also, see how much the globe is very small, and we can see again, yes, the eyelid is dropped on the globe, but there is no much of ptosis because the eye is so atrophic and there is a scar pulling up the upper eyelid after accident or trauma. So we can have enophthalmos without pseudotosis, or can we have enophthalmos because the globe is smaller and smaller, and we call this atrophia bulbi or small globe or atrophic globe. Inspection also, we have to look at what is surrounding the eye. We can see tumor masses like the picture on the upper left side. This is a sebaceous cyst hanging down from the upper eyelid. On the right side up there, on the upper right side, there is a dermoid cyst, congenital dermoid cyst, but usually at the angle, and we need palpation to see if it's the consistency and if it's painful or not, tender or not. And lower there is left lower side, there is basal cell carcinoma of the skin, and we can see the scarring and crustation. And on the right side down there is dacryocystitis, acute dacryocystitis with swelling of the cyst of the lacrimal cyst. And we can see how the inflammation and the redness seen by this dacryocystitis. So inspection can give you a clue about the diagnosis, but you need further confirmation by doing palpation or different further tests. Also, gross disfigurement. You can see a huge mass on the like the baby on the right side, like hemangioma. It's congenital and it's born there, and it increases while he's crying. And we can see also the picture on the left side where the skin lesion, like inflammation, like crustation, like pus and fistula in the nasolacrimal part. So we need to look at this and not to miss this during observation. Also, while the eye is closed, we can see multiple deposits under the skin, and we call this vancyllasma, which means cholesterol deposits or lipid deposits under the skin. And it's very important to inspect this and to tell the patient to go and do lipid profile to see how much elevation of his lipids like cholesterol, triglycerides, and it can save the patient because these patients are mostly atherosclerotic and they can go into cardiac attacks. Also, inspecting the skin is very simple to diagnose when the patient comes in with herpes simplex, vesicles like in the left side, or herpes zoster, crustaceans and scarring along the fifth cranial nerve division, and we can diagnose this from just observation if he had herpes simplex or he had a herpes zoster inflammation. Inspection also by the naked eye, if there's any discharge coming out of the eye, like on the left side, this is like a mucopurulent discharge. On the right side is a pure purulent discharge with crustacean and even sticky lids, and we can diagnose the patient from this, but we need further investigation in the form of culture to know the type of organism. Inspection also, any abnormal color. Look at the child on the down left there, the first picture on the left side. We can see a blue coloration coming out of the eye, which we call ophthalmos or congenital glaucoma, and it gets blue color because of the stretch of the cornea. In the middle, we have a grayish coloration because of the corneal opacity, and we can see the vascularization of the opacity. And on the right side down there, there's a red color due to subconjunctival hemorrhage over the sclera. So any color has to be interpreted and knowing the relation to the eye. Then comes the corneal light reflex. We can see abnormal corneal light reflex like vascularization. It could be superficial, it could be deep, and these vessels is not supposed to be there because we don't have any vascularization on the cornea. We have only clear, crystal clear cornea. So the superficial and deep vascularization can be differentiated by which is of them riding the limbus, which is branching, raising the epithelium or not. And it happens in different disease, like in superficial, happens in superficial keratitis, in trachoma, like on the left side, we can see the trachoma spinous out there. And on the right side, it's deep due to interstitial keratitis or in syphilitic or leprotic keratitis. And we can see the vessels clearly creeping, and we can see it end at the limbus, or sometimes it extend close to the limbus in a grayish or ill-defined parallel radius branching. Abnormal reflex. We can look at the child coming with a yellowish reflex instead of the red reflex we see, and this means that we have a mass behind the pupil, and this could, we call it leukocoria or white pupil, and this could be diagnostic in children for retinoblastoma or malignant tumor coming in young age from 1 to 4 years of age. So it's very easy to distinguish this by inspection. Then comes to abnormal position of the globe. Let's speak about the globe itself. If it's parallel to each other, inward deviated, we call it esotropia or phoria, and the difference between the tropia, it's permanent deviation, but the phoria is deviation only when you cover one eye. Or outward deviation, we call it divergence quant of exotropia. Upward deviation, we call it hypertropia. Downward deviation, hypotropia, and there is deviation along the anteroposterior axis, or inward or outward, which we call it cyclotropia or cyclophoria, where the patient goes around the anteroposterior axis. How we can detect this amount of deviation? By corneal light reflex. They call it Hirschberg test. When we shine a flashlight in the patient's eye, we can see two lights inside the pupil. Actually, they are catopteric images, reflected images from the cornea behind the pupil. And it's like a mirror reflection. Any object upon convex anterior surface, and we all know that the cornea has a convex anterior surface, so it's reflected on the back of the pupil. We call it Purkinje image. Normally, it's bright, sharp, well-defined, central. We can see the two lights where the arrow is pointing, the two lights in the center of the pupil, and it's exactly the reflection of the light from the surface of the cornea on the back of the pupil or on the anterior surface of the lens capsule. Corneal light reflex, is there any ocular deviation? The corneal light reflex which change the direction, it will not be in the center, and according to the direction, the deviation will be diagnosed. This is a video you can see showing the Hirschberg reflex, and you can enjoy the video, and you can rewind it, and you can see it many times, and we can see how it works.
To conduct a corneal light reflex, you'll need a pen light and a patient. You'll ask your patient.
So measuring that, it means that we can know if the light reflex is not in the center, roughly measuring the deviation by knowing the location of the light reflex. If it's at the edge of the pupil, or it's away from the pupil, or it's in the middle of the iris, or the edge of the limbus, so it means that we have deviation. Location of the corneal light reflex, if it's 1 millimeter deviated, it will be 5 degrees, or what we call 10 prism diopters. Like the picture on the left side down there, it reflects at the border of the pupil. It means 15 degrees because this is our almost 3 millimeter deviation. Look at the reflex on the right side, the patient on the right side, the reflex happens at the limbus, which we can measure it as 45 degrees, which is about 9 millimeters. This is a rough measurement. Look at the center of the pupil. If the light is deviated to the edge of the pupil, it's a 15 degree. Between the edge of the pupil and the edge of the limbus or the sclera, so it's 20 degree or 25 degree in between. When it reaches to the edge of the cornea, or we call the limbus, where the cornea meets the sclera, it's a 45 degree. When it's in the middle of the sclera, away from the cornea, it's 60 degree roughly. So it depends on the amount of deviation in millimeter. And here is a diagram showing that exactly. The first picture is normal light reflex. The light reflex is in the center of the pupil. 1 millimeter deviations equal 15 diopters, 2 millimeter equal 30 diopters. So the second picture is 1 or 2 millimeter deviation. The third picture is 3 millimeter deviation, and it's 45 degree at the edge of the cornea, and 4 millimeter deviation equals 60 diopters. Here's esotropia, means that the light reflex will be at the temporal edge of the pupil. First picture, the light is at the temporal edge of the pupil, so it means the eye is deviated inward against the position of light. Second picture, exotropia, when the light reflex is shifted to the nasal part side of the pupil. Hypertropia, the eye is turned up and the light reflex is deviated to the lower edge of the pupil. And hypotropia, the eye turned downwards, or the light is seen at the upper edge of the pupil, and every 1 millimeter of deviation of the center of the pupil, about 15 diopters in prism diopters. Let's have examples. This is ocular deviation, or what we call inward deviation, right inward deviation and the patient on the right and the left side, and left inward deviation of the patient on the left side, and this is what we call esotropia. So the light reflex can be seen at the temporal edge of the pupil, which means that the eye is deviated inward. As we said, if it's on the temporal edge, so the eye is going nasal. If it's in the nasal edge, the eye is going temporal. Here's another example of left outward deviation of 45 degree, because we can see the light reflex at the edge of the limbus or at the end of the cornea. So we can say this is exotropia 45 degree. Here's left downward deviation or hypotropia, because look at the right side, the light is in the center of the pupil, but on the left side, the light is slightly deviated up. So it means that the eye is going down, or what we call the hypotropia. Look at this patient, right upward deviation. It might be very minute and cannot be seen, but we can see here the right upward deviation. So it means that the left is the normal, where the light reflex is in the center, but the right, look at the light reflex, it is going down. So it's hypertropia. So once we see the light at the edge of the lower part of the pupil, so the eye is going up, when we call it hypertropia. This is detection of strabismus and corneal reflections, a movie from the internet, and you can enjoy listening it, and it will explain everything I said in the last few slides, and it's a very nice movie to watch, and you will be testing yourself if you know what's the tropia and what is the phoria.
Hi, my name is Corneal, and you're watching the video Detection of Strabismus, Corneal Reflex.
The last thing we are going to speak about is the corneal sensory reflex. This is not by inspection. This is need some interference, but it's very important to say that we can include it in this lecture. What is the corneal sensory reflex? The cornea is a very sensitive structure. If you touch the cornea, you have a blink reflex. This is, as all reflexes, has an afferent, which is a sensory, and efferent, which is a motor. You touch, you use the sensory afferent, you have reflection through the motor closing the eye. The reflex is mediated by the nasociliary, which is a branch of the ophthalmic branch of the trigeminal, which is the fifth cranial nerve, and sense stimulation on the cornea. The temporal and zygomatic branch of the facial, so it comes from the seventh cranial nerve, initiate the motor response, which is blinking. When you touch the cornea, just touching the cornea, not hurting the cornea, there is reflex blinking, and the reflex is driven via interneurons in the medulla oblongata. This is the corneal sensation, how we can do it. This is not by observation. We have to touch the periphery of the cornea by a very thin tip cotton wool, like touching the periphery of the cornea. This is why we're tapering this, because we cannot go with the whole part of the cotton wool. We can taper it as a very thin and long tip, and comes from the side of the patient, because if we go directly in front of the patient and try to touch his cornea, you will have a fear reflex automatically and you cannot touch the cornea. So you come from the side, the patient cannot see you most of the time, and you touch the cornea. Suddenly, once you touch the cornea, you will have a reflex blink or closing the eye. And it's recommended, as I said, to approach the patient from the side. And we have to test all four quadrants, upper, lower, nasal, temporal, and record the sensation of each quadrant, because sometimes Decreased sensation of loss of sensation is diagnostic of many diseases, like losing sensation and some of the diseases affecting the nerve supply of the cornea, like the ulcers. Some of the ulcers has hypothesia or less sensation in the cornea, like the herpetic ulcer. Other disease also might affect the sensation of the cornea. It could be diagnostic for other disease. Thank you so much for your listening, and I hope you enjoyed the lecture, and please keep and stay safe. Thank you so much.